Now let's delve a little bit more into some of the specific psychotropic medication classes and some of the evidence for treating behavioral disturbances in dementia. So let's start off first talking about antipsychotics. Generally, our starting range for these medications is going to be about a quarter to half of the general starting dose for a general adult. So for instance, risperidone, we might start at kind of 0.125 or 0.25 milligrams. So antipsychotics do have risks outside of the FDA black box warning for mortality. And some of the things include kind of cognitive worsening, sedation, difficulty with gait and falls, and there's also an association with increased stroke risk. Antipsychotic medications as a class can cause prolongations to the QTC interval, as well as metabolic side effects such as weight gain, dyslipidemia, and diabetes. And while some of these side effects might be less of a concern in patients with limited life expectancy, we know that from the time of diagnosis to death, that can be quite variable for patients with dementia. I'll mention some of the caveats for Parkinson's disease and Lewy body dementia psychosis. This is a situation where patients tend to be very sensitive to antipsychotic medications and can have significant worsening of extrapyramidal symptoms. And so generally, we're going to start with very tiny doses of these medications. And as I said, utilize medications with lower D2 blockade. We also know that the extrapyramidal or motor side effect potentials are not equal, that medications like clozapine and quetiapine are going to have less risk of that as compared to more typical agents like risperidone and haloperidol. This is also a situation where cholinesterase inhibitors can actually be quite helpful. And so rivastigmine or donepezil, cholinesterase inhibitors have shown some improvement, especially in treating visual hallucinations in Parkinson's disease dementia, as well as Lewy body dementia. Pimavanserin is a newer antipsychotic medication that came out a few years ago. It has a novel mechanism of action in that it has no D2 blockade and works as a selective inverse agonist at the 5-HT2A receptor. The dose range generally starts at 17 milligrams with a max dose of 34 milligrams per day. This medication can be helpful in that it does not cause appreciable extrapyramidal side effects. However, it's important to notice that it still has the same FDA black box warning for increased mortality in use with dementia-related behaviors. And additionally, it also causes prolongation to the QTC interval. Cholinesterase inhibitors and Memantine, these are medications that are used to help, generally we'll say, slow the kind of progression of cognitive impairment in dementia by about a 6 to 8 month period of time. And these medications can be used to treat behavioral symptoms in dementia as well. These medications do have some side effects that you want to be aware of. The most common side effects with the cholinesterase inhibitors, like donepezil, would be GI side effects, so things like nausea, vomiting, diarrhea. There's a lot of cholinergic neurons in the brain. There's also a lot of cholinergic neurons in the gut as well. These medication and related to those GI side effects can cause decreased appetite and weight loss. Bradycardia is also a concern as well. Confusions, headache, and dizziness. In terms of how well these medications improve behavioral disturbances in dementia, there's been a couple of meta-analyses that have been done that show that there is a statistically significant reduction in behavioral symptom scores using what's called the neuropsychiatric inventory. And cholinesterase inhibitors overall had an effect of reducing the neuropsychiatric inventory by 1.7 points. However, the neuropsychiatric inventory is a scale that goes from 0 to 144. So a reduction of 2 points on this scale, although statistically significant, has a very small effect size. That being said, I think anecdotally, all of us have probably had experiences where these medications have been helpful for patients. Just the pooled studies show that the actual reduction in symptoms is quite modest. So some key points. So clinicians should really try to use the lowest effective dose of antipsychotic medications to treat behavioral and psychological symptoms of dementia and attempt gradual dose reductions when possible. Antipsychotics are associated with a host of other side effects in addition to the US FDA boxed warning for increased mortality. And special considerations should be given to using antipsychotic medications with low D2 blockade in patients with Lewy body dementia or Parkinson's disease dementia. Cholinesterase inhibitors and Memantine show a statistically significant improvement in behavioral and psychological symptoms of dementia, however, with a somewhat limited clinical impact.